Hi, this is Serge Cordian coming to you from ACC 2022 in Washington, D.C. I'm very pleased to be joined today by Professor P.J. Devereaux.
Thanks so much for having me.
Very good to have you. You presented yesterday the results of POISE-3. I mean, tranexamic acid is not a medication I thought I'd hear about on ACC. It takes me back to my step 1 days. As you were saying, we were just talking before this started, and we focus a lot on making blood thinner and thinner, and we don't really think about the other side of the equation.
Yeah, and I mean, both sides of the equation are important. Obviously, in cardiology, we're spending a lot of our time using antiplatelets, anticoagulants, which are incredibly effective. At the same time, we obviously not infrequently see the complications in bleeding, and bleeding in the surgical setting can get a lot of patients into serious trouble, and it also delays the start or the reactivation of our antiplatelets and anticoagulants. So trying to find ways that we can really prevent serious bleeding around the time of surgery has a number of upsides.
I don't really know a lot of uses for tranexamic acid. Is there already a use for it in surgical settings?
Yeah, so the area that it's mainly used is in cardiac surgery. So there's been a lot of large trials that have unequivocally shown that you can use tranexamic acid safely in people having cardiac surgery. And obviously we're dealing with much smaller arteries than we're typically dealing with in the non-cardiac surgery setting. And it's been shown to be very efficacious and safe in that setting. And that was one of the impetus behind us actually doing this, because a lot of our research, which is really focused on myocardial injury around the time of surgery, has also identified that bleeding is a common pathway to lots of other problems that get us into trouble. And so given the work that was done in the cardiac surgery setting, we wondered whether or not we could extend this into the non-cardiac surgery setting.
That makes sense. What was the design of POISE-3?
So POISE-3 was a randomized control trial. Everyone had to be randomized to tranexamic acid or placebo. They received 1 gram at the start of surgery and 1 gram at the end of surgery, or placebo. It was also a partial factorial. The results of the partial factorial will be presented on Monday here at the late-breaking trial session. And that was informing the question that, a common question we all have is that when people are coming to non-cardiac surgery and they're on antihypertensive medications, what should you do with those antihypertensive medications? And also, it informs the question of intraoperatively, anesthesiologists commonly target MAPs, mean arterial pressures of 60 or greater, but there's been actually research suggesting maybe we should be targeting higher MAPs of 80 or greater. So that was also looking at a strategy of a hypotension versus a hypertension avoidance strategy. Again, that'll be reported separately.
Great. What did you guys find?
So what we found was we randomized 9,535 patients, 114 centers, 22 countries. And tranexamic acid worked. It prevented the primary composite endpoint, which was life-threatening major and critical organ bleeding, which occurred in 9.1% of patients in the tranexamic acid group and 11.7% of the patients in the placebo group, consistent with about a 25% relative reduction in the risk, p-value less than 0.0001, so pretty unambiguous results. We also demonstrated that almost all forms of the way that you can look at bleeding, so if you talk about bleeding independently associated with mortality at 30 days, ISTH bleeding, need for a transfusion, need for 2 to 4 units of transfusions or greater than 2, all those things consistently reduced by about 25% with tranexamic acid. We also, because tranexamic acid is an antifibrinolytic drug, an issue is safety. So the study was also set up to demonstrate the superiority for preventing bleeding, but also to establish the safety side of it and hopefully not creating thrombotic events. So a priori, we looked to see whether or not we'd increase vascular events, and we set a non-inferiority margin of the hazard ratio, 97.1% confidence bound of 1.125. In the end, what we saw was that 649 patients in the tranexamic acid group had a major vascular event, and 639 in the actual placebo group. So despite just under 1,300 events, there was only a difference of 10 events between the two groups. The hazard ratio is 1.023, but the upper confidence bound did surpass our non-inferiority boundary, so we can't claim non-inferiority. However, when you look at the results and you also put the tranexamic acid data into the context of all the preceding tranexamic acid data, including cardiac surgery. So prior to, just in 2021, there was a meta-analysis published of all the prior trials to POISE-3. And in it, they had 2,600 thrombotic events across those trials. The hazard ratio was 1.0. And so what our result, and also given that our result supports that there's a 96% probability that the hazard ratio is less than 1.125, it certainly is encouraging that it unequivocally does prevent bleeding, and it is very encouraging on the safety side.
Something to be considered for non-cardiac surgeries, with the consideration of a small potential increase in events that may or may not be significant.
Exactly. So, healthcare providers and patients will have to weigh off a clear, unequivocal benefit of a 2.7% absolute reduction in bleeding risk with a low probability, small 0.3% absolute increase in, vascular events. But again, it was non-significant, and when you put it in the context of all the preceding data, it certainly looks very encouraging on the safety side.
Very interesting data. PJ, thank you so much for joining us today, and congratulations on the presentation and the manuscript that was published at the same time.
Thank you so much for having us.
Thank you for joining us. And thank you, everybody. We are live from ACC 2022.